Let us see. Let's see beta who will respond. Question number 11. A 38-year-old lady with foul-smelling blood-stained ear discharge for 1 year. Imaging, all the radiological imaging confirmed the canal mastoid fistula, but intact tympanum was normal. There was no history of any trauma in the past. Which of the following is the best treatment? Any student. 38-year-old lady with foul-smelling discharge for 1 year. There is one canal mastoid fistula. What intact tympanum is normal. What will be the best? I'm waiting for response. Anyone who can write in the chat box what will be the best possible answer of this MCQ. Yes, any student? What will be the best possible answer? Option 1, 2, 3, 4. Dr. Mane, cortical mastoidectomy. Why? Tympanum, intact tympanum is normal. There is no history of any trauma. Middle ear is normal. When middle ear is normal, it means two options rule out. Middle ear is normal, modified radical though not at all. In non-malignant cases, I can rule out first option to be ruled out. Option 3, modified radical, because tympanum is normal, I will not go for modified. So it can be either canaloplasty or it can be cortical mastoidectomy. Now patient, there is no history of any trauma. There is no trauma. Middle ear tympanum is normal. Better option, patient is having for last 1 year discharge, or there is one fistula. So what is the treatment of any canalomastoid fistula? It will not be cortical, but I will not go for cortical because my CT radiological findings are normal. I will be trying first for canaloplasty. First line of treatment, best option here will be canaloplasty. Patient not responding to canaloplasty. If the patient reoccur, if this patient again reoccur, I will go for option 2. Option 2 will be the right answer for resistant cases. Option 1, first we'll try canaloplasty. It is documented if there is any fistula in the external auditory canal going to mastoid and the rest of middle ear is normal, we'll try for canaloplasty. So every student just make a note in question number 11. The best possible answer will be a canaloplasty. Done. Question number 12. A 50-year-old female complaining of hearing, canaloplasty will be the best option. Okay, 50-year-old. I'm coming back on this question number 11. Beta, tympanum they have given normal. There is no history of trauma. Only fistula is there. What is the best treatment? Clear? If the examiner give the option of resistant case, I will go for cortical mastoidectomy. But best treatment as such in this given MCQ will be option 1, canaloplasty. Nice question number 12. 50-year-old female with hearing loss, vertigo, pain, tinnitus. CT examination, hyperdense pedunculated mass arising from tympanous suture lateral to isthmus. What is the diagnosis? Let us see option first. 4 options given to you. Any student who can tell me which option to be ruled out first? First, I'm ruling out keratosis obturans. Why this patient cannot have keratosis obturans? Let us dissect the MCQ. Why this patient cannot have? I have given you little bit of patho finding, little bit of anatomy segment, and then clinical finding of hearing loss, vertigo, pain, tinnitus. Why this patient cannot be keratosis obturans? Can you tell me which 2 things are going against the diagnosis? Which 2 things are going against the diagnosis? Yes, it is 50-year-old female. Growth abnormality. If it is a growth abnormality, it will be bilateral 1 point. It can be or it will be young age. So it is in the age group of 5 to 20. So one option, the age is going against keratosis obturans. Option B ruled out. Anyone who can tell me why you will rule out option A? Why it cannot be cholestoma of the canal? Ear down, external tympanic membrane seems to be normal. There is no evidence of necrosis. There is no evidence of ear discharge in the MCQ. I will rule out the option cholestoma. This patient cannot have cholestoma. The option going, either this can be a polyp in the external auditory canal, or this can be osteoma. This can be polyp, this can be osteoma. Bird eye view. If I focus my eyes on osteocyte, bone, periosteum. What these three patho finding going in the favor of? If the word osteocyte, bone is there, periosteum is there, so it is more chances, more probability that this is something to do with osteoma formation, not polyp arising from the facial. Done. I hope I'm understandable. In this MCQ, keratosis obturans ruled out because old age. It is in the young age. Cholestoma rule out, no necrosis, no evidence of ear discharge. Polyp can be there, but osteocyte, bone, periosteum word. So answer will be osteoma, which is of two types. If it is unilateral osteosis, bilateral, it is exosteosis. Polyp from the facial lump. Always remember, ear polyp. If there is a ear polyp, can you reply in the chat box? What is the difference between the nasal polyp and the ear polyp? If there is some ear polyp, can you avulge it out? Can you pull it out? Can you pull the ear polyp out? No, we can never avulge the ear polyp. Why? Because it may arise from 3S. Which are the 3S it may arise from? It may arise from semicircular canal. It may arise from seventh nerve. It may arise from your stapes. Always remember this point. Therefore, this polyp, ear polyp should never be avulged out. Ear polyp should never be avulged out. What is the treatment of osteoma? Will be a surgical excision. Would be surgical excision. Coming to the next one. Nicely formatted question number 13. That is, I'm giving you one slide. There is some pathology finding on the tympanic membrane. There is some white patch on the tympanic membrane. First of all, any student who can make a diagnosis. Question number 13. Can you make the diagnosis? Yes, anyone? Why vertigo? Why tinnitus? Very nice. Dr. Samya, write one statement. Any pathology in the ear, from external ear, middle ear, inner ear, can have vestibular symptoms. Always remember this point. Patient tinnitus, ringing sensation in the ear, vertigo. If there is any pathology in the external, they are the hardcore symptom of inner ear. If I give you the MCQ, vestibular symptoms, tinnitus, vertigo are the hallmark feature of external ear, middle ear, inner ear. You have to choose one. You choose inner ear. But the symptom of external ear, middle ear, they may have some vestibular finding, but they will not be intense as inner ear findings. Like there is a pathology in the inner ear, very severe, intense vertigo, vestibular symptom. But if there is any pathology, whenever there is any abnormality in the external ear, middle ear, it causes unwanted symptoms, which can be vestibular symptoms. So it can be excellent. One of the best reply in chat box, Dr. Divya, this is tympanosclerosis. This is a sclerotic patch over the tympanic membrane. Done. Tympanosclerosis. So for MCQ, I can ask you, study the following slide. I go for tympanometry. I go for tympanometry of the patient. If I go tympanometry of the patient, which graph will be there? Which tympanogram can be seen in this patient? Anyone who can reply in the chat box. We'll attempt the options. We'll crack each and every option. First, tell me if this slide is given to you, which tympanogram? They can show you one slide. They can ask you the either patho finding, or they can ask you the tympanometry. Which tympanogram? Tympanosclerosis. It will be hypermobile or hypomobile. It will be hypomobile tympanic membrane. Yes, I'm waiting for response in the chat box. It will be which graph? It will be AS graph. It will be hypotympanosclerosis. Tympanofibrosis graph is AS. Now let us read the option. Calcification only within the tympanic membrane. No. Tympanosclerosis. Any student who can tell me what is the most common site of tympanosclerosis? It is here, malleus beta. It is malleus. It involve ossicles, not only tympanic membrane. Calcification only within the tympanic membrane, false statement. So it is here, tympanic membrane, malleus, one of the most common site. Usually does not require any treatment. Here, let us read other option to rule out. Insertion of the tympanostomy tube, that is grommet, is the most appropriate treatment. Is it true statement? Option C. Is it true statement? If there is a sclerotic focus, if I give you a hypomobile tympanic membrane with a white patch on the tympanic membrane, will you insert a tube? Not at all. Insertion of grommet is the cause, not the treatment. Capital letter. Frequent use of grommet. What can be the, I can ask you an MCQ, what is the cause of underlying slide? What is the underlying cause of the given slide? They can ask you this MCQ. It will be frequent overuse of grommet. Grommet is not the treatment. It is your cause of tympanosclerosis. Hearing aid may be the underlying cause, not at all. Hearing aid can be used for treatment. But what is the treatment for tympanosclerotic patch? Hearing aid helps a lot. Patient have mild hearing loss. In this patient, you will get mild airborne gap will be there, and the hearing aid is beneficial. So it is treatment part. Grommet is the cause. It does not require any treatment usually. Most of the cases doesn't require treatment. Clear? So why, which 5 keyword for the slide? Hypomobile tympanic membrane. It is AS tympanogram. Overuse of grommet is the cause. Hearing aid is beneficial, and most of the patient doesn't require any treatment. Please write these 5 points if they ask you MCQ on tympanosclerosis. These are the important point. Done. Coming to the next question, number 14, one of the easiest MCQ beta. Any student who can tell? Question number 14. Diabetic patient. Word diabetic, beta diabetic आते तो हम question ही नहीं पढ़ेंगे. We will just confirm कि it is ear patient. If it is ear patient, it is malignant otitis externa. And malignant otitis externa means pseudomonas. Am I understandable? Though important concept. First concept, the word diabetic. If diabetic word is there, MCQ from ear, diagnosis will be malignant otitis externa. MCQ from nose, it will be mucormycosis. MCQ from oral cavity will be going for Ludwig abscess. Just remember this point. बेटा ये 3 concepts हैं. अगर MCQ ear से, it is malignant otitis externa. MCQ from nose, it is your mucormycosis. MCQ from oral cavity, it is Ludwig abscess. One important cause. One important flowchart. One second important point. All ENT infection. Just make a golden rule. All ENT infection caused by strepto. Exception always prove the rule. So all ENT infection caused by strepto except fruncle. Fruncle is caused by staph. It is caused by staph. Fruncle. And 4 conditions which are caused by pseudomonas. So just remember this formula. Which conditions are caused by pseudomonas? One is perichondritis. One is perichondritis. One is your diffuse otitis externa, malignant otitis externa, and to your surprise, CSOM. They are caused by pseudomonas. So examiner can ask you this MCQ. So these 2 important tables. Mucormycosis, microbiology, medicine, they will teach you nicely. But as for ENT, just remember mucormycosis, diabetic patient, black necrotic area on the nose, on the cheeks. If there is necrosis over the ear, that is your malignant otitis externa. So these both starting from alphabet M, they are having some black necrotics. Ludwig abscess. What is a key word for Ludwig abscess? Woody swelling. Just remember, if there is a woody swelling below the chin in a diabetic patient, that is your Ludwig abscess, submandibular abscess. Now coming on this MCQ, let us crack. Which are the 5 to 6 keywords for malignant otitis externa? They can ask you the cause, that is your pseudomonas. They can ask you the hallmark feature. What is the presentation of this patient? This patient present with ear discharge with granulation in the canal and facial nerve palsy. Always remember, presentation of malignant otitis externa is your ear discharge with granulation with facial nerve palsy. Which two important investigation we do? Technetium 99 scan. One is gallium scan. Technetium 99 scan is for diagnosis. Gallium scan is for prognosis. Always remember, technetium 99 is for diagnosis, gallium scan. Any student who can write in the chat box which lab finding can be used for prognosis, which lab finding we can use for prognosis, that is your ESR. In this patient of malignant otitis externa, ESR is very high. So when we start the treatment, within 2 weeks, it comes down. Within 2 weeks, it comes down. Then, so for as prognostic marker, we are using ESR. Pharma, they can ask you which drug, what will be the drug of choice? Cephalosporin, third generation cephalosporin. Just remember, this is nice. Let us crack this question nicely now. If examiner asks you the drug of choice, it is your third generation cephalosporin. Not given in the choice. Cephalosporin is not given. We will go for penicillin group. Done. And if even penicillin is not given, we go for ciproflox. One of the students was asking this question in the Telegram group few days back. Let us crack this question now. The third generation cephalosporin not given in the MCQ. All the 4 choices, third generation is not there. I will choose any penicillin group. But sometimes the examiner give a tricky MCQ. Examiner give a history a patient is not responding to cephalosporin. Patient is resistant to cephalosporin. Which of the following is the next drug of choice? Then out of 4 options, I will not choose penicillin, because if the patient is not responding to cephalosporin, he will not respond to penicillin. Same family. Then in that condition, resistant cases, I will directly jump to ciproflox. Then I hope you are getting my message. Cephalosporin not given, go for penicillin. If resistant case, go for ciproflox. Any student who can tell me which surgery we do? Modified radical mastectomy? Not at all. We do a simple procedure. We do canaloplasty. We just do canaloplasty in the patient. So just remember, in this patient not responding, we go for canaloplasty. Done. Coming to now, I'm taking you to the inner ear segment. Now concentrate on the board. After doing mastery of external ear, middle ear, all the basic clinical points, we are entering into question number 15. Yes, a 70-year-old patient with having imbalanced bilateral pulsatile tinnitus. Pulsatile word, 70-year-old. Anyone who can make a diagnosis better just by reading 2 words. 70-year-old patient with pulsatile symptoms, tinnitus. I will go in the favor of yes, pulsatile symptom. The first possibility come glomus tumor, but there is no reddish mass, no red mass given in the MCQ. So patient have some pulsatile tinnitus, hypoacusis, while being very sensitive to certain sounds. He noticed that when walking on a firm ground, he could hear, this is his own footstep. He could hear his own footsteps. These symptoms have been reported for years, but recently got aggravated. Tullio's phenomena positive. Very nice finding. Tullio's phenomena positive. What is the differential diagnosis? Let us crack this one. I will try my best to give you the concepts of inner ear with the help of this MCQ number 15. Tullio's phenomena positive. What is Tullio's phenomena? Tullio's phenomena means patient is having discomfort in noisy surrounding. So what is a differential diagnosis? Differential diagnosis, it can be because of oversensitive cochlea, that is which patient? Sensory deafness. In sensory deafness, it is oversensitive cochlea. Tullius phenomena. Second, Tullius phenomena can be seen when there is some fistula, some dehiscence is there, some communication between brain and middle ear, inner ear is there. We can get Tullius phenomena. It can be trauma. It can be because like in fenestration surgery, fistula formation can be there. It can be in superior semicircular canal dehiscence syndrome. So Tullius phenomena, two important differential diagnoses. One is recruitment. Very good, Dr. Divya. It is your not all these students who are writing Meniers in the chat box is a wrong answer, beta. You should write sensory deafness, not Meniers. Any sensory deafness, it can be Meniers, it can be presbycusis. So any sensory deafness, there is a recruitment phenomena, and because of recruitment phenomena, patient is having discomfort. That discomfort is known as Tullius, or it is superior semicircular canal dehiscence syndrome. Now, patient notice his own voice, own footstep. It means that this patient is not going in the favor of sensory deafness. It is somewhere semicircular canal dehiscence syndrome. I hope you are getting my point. Clear. Let's read the other option. On no nystagmus, no CNS symptom, or vestibular signs were by exceptionally. This is something going against the diagnosis. Vestibular signs were normal. Choose the most appropriate statement. Tullius phenomena positive, with patient can perceive his own footsteps with imbalanced bilateral tinnitus. It is going more in the favor of your semicircular canal dehiscence syndrome. Clear. This patient will be having, I always give a mnemonic, conductive deafness with CNS symptom. Conductive deafness with CNS symptoms. Most appropriate statement. Cervical VEMP confirm the high altitude, high threshold. Little bit difficult, but I promise this MCQ will help you to crack all the concepts of this topic. 1 point, superior semicircular canal dehiscence syndrome. What is the investigation of choice? Investigation of choice is VEMP, vestibular evoke myogenic potential, VEMP. Now, cervical VEMP confirm high amplitude with high threshold. Let us leave this statement, read the next option. Investigation of choice is HRCT. Investigation of choice is VMP. HRCT is for radiological. So if the word radiological investigation of choice, I will go for HRCT. Overall, it is VEMP. Rehabilitation sessions will include hearing aid counseling. Hearing aid counseling. Hearing aid, yes, is a true statement. This patient can have a benefit from hearing aid, yes, because conductive deafness is there. It seems to be true. Immediate surgical intervention required. Wait and watch is the treatment. Option 1, confirm high amplitude with high threshold. No, it is low threshold. It is low threshold. I'm understandable. So which will be the most appropriate statement in this patient? I will advise hearing aid is a true statement. VEMP threshold will be reduced. Why reduce? Even in my lecture I highlight this point. Okay, in semicircular canal dehiscence, when there is a communication between the brain and the inner ear, communication between brain and the inner ear, so threshold will be reduced. At the low threshold, brain will respond. The brain will give signal to sternocleidomastoid to relax. Are you getting my point? Can you tell me which patient will have high threshold? Dead ear. If the patient will in dead ear, amplitude will not be high, threshold will be high. So high threshold is a feature of any sclerotic area, any fibrotic or dead ear, dead inner ear. But reduced threshold is feature of superior semicircular canal dehiscence syndrome. 1 day before the examination, superior semicircular canal dehiscence syndrome. Very important topic. Conductive deafness with CNS symptom. Investigation of choice. VEMP. On VEMP, what we will see? We'll see decreased threshold. Radiological investigation of choice. HRCT. Treatment of choice. Wait and watch. Plus minus patient can have hearing aid. We advise hearing aid. So in this MCQ, question number option C, third option will be the best choice. Clear? Done. Coming to the next one. Yes, kindly update in the chat box. Question number 15. Is your concept clear, beta? How I am ruling out the option 2 and 4. directly ruled out. Very close choice 1 and 3. 1 low threshold, it is not high threshold, therefore option 1 is a false statement. Then rehabilitation program is a true. Kindly update in the chat box, is this concept of question number 15 clear? Coming to the next one. A 45-year-old female was admitted with 3 weeks of history of cough, sore throat and dyspnea. After a few days into admission, the patient was having some hearing loss. Otoscopic examination, I'm showing you right tympanic membrane. This is a typical history going URTI, upper respiratory tract infection, landing up into ASOM. There was bilateral pulmonary changes which are feature of COVID on CT with confirmatory by positive polymerase chain reaction test of nasopharyngeal swab. She was discharged from the hospital after 2 weeks. Choose the most ENT manifestation. So I have given you 4 symptoms in the history. Out of these 4, which is the most common ENT manifestation? So this patient is a COVID patient who land up with your ASM, acute suppurative otitis media. So the most common symptom is anosmia, not at all. It is sore throat. So just remember, most common ENT manifestation is sore throat, and non-ENT manifestation will be your fever. So if the examiner asks you non-ENT, that is fever. So not anosmia. Okay. Coming to the question number, not anosmia, Dr. Sagar. It is not anosmia. Question number 17. A 52-year-old patient with left atoria that was associated with otalgia, a humming sound in the ear, progressively worsening, partial deafness in the left ear. The clinical examination found to have a patent external auditory canal with reduced scalp. Again, nicely formatted question. I am taking you back into the anatomy of external ear, middle ear. So patient is having some sound in the ear, some ringing sensation. Partial deafness means mild deafness. Left patent external auditory canal with reduced caliber. The tympanum was intact. Tympanic membrane is intact. Middle ear is having some left atoria. It means that patient is having some pathology in the external auditory canal. CT examination of the petrous bone was done, and it demonstrates left external auditory canal reduced caliber due to partially filled eroded bone from the posterior wall. Nicely formatted question. What is the most inappropriate statement? So I want to choose false statement. Make a habit of writing alphabet T or F. So beta, whenever you are attempting the MCQ, always make a habit. Okay, you are going for a true statement or false statement. First of all, tell me what I'm showing you. Any student who can make a diagnosis. Little bit difficult, but yes, we all together will crack it. There is some external auditory canal reduce, some necrotic, some eroded bone from the posterior wall. Age of the patient is here, 52-year-old. Pathology in the external auditory canal. Keratosis obtrans cannot be there. Old age. This is a typical presentation of anyone who can make a diagnosis. I'm waiting for the diagnosis. Anyone? Little bit difficult question, but yes, this is cholestroma of the external auditory canal. This is a typical presentation of cholestroma of the external auditory canal. Clear? Clear. Spontaneous cholestroma of the external auditory canal is normally considered to affect elderly patients. Is a true statement. Treatment consists of frequent cleaning, debridement of the necrotic tissue. Tympanic membrane is usually intact. It is usually unilateral, not bilateral. Clear? So cholestroma in the external auditory canal, it is unilateral. Clear? So option 2, 3 and 4, they are the true statement. Whether these questions will help you in the examination. It is a very rare presentation of the patient of the cholestroma of the external auditory canal. This flow chart should be in your mind, where I usually must of this base chalky white appearance. If there is chalky white mass in the external ear, the students are not, there is no response in the chat box. If you can't attempt this question, no worries, better just use this platform to learn. Chalky white mass in middle ear. In middle ear, chalky white mass, always cholestroma. In the external ear, two possibilities. It can be cholestroma, it can be keratosis obtrans, It can be keratosis, obtrans. How will differentiate keratosis, obtrans? It is bilateral. Young age, no necrosis, no necrosis. Here cholestoma necrosis will be there. It will be old age, not young age. Clear? So just remember. So option A. Coming to the next one. Little bit difficult, but we all together will crack it again. Question number 18. A 44-year-old female with a history of hypertension, headache, pulsatile tinnitus, refractory to the medical treatment after onset of left autalgia. Patient have some hearing loss. On examination, left tympanic membrane was intact. Can you appreciate it? I am jumping on the keyword pulsatile tinnitus, followed by patient is not only having autalgia, no ear discharge. Clear? This red mass deep to the posterior inferior quadrant. But a pulsatile tinnitus with red mass, diagnosis going in the favor of any student. Diagnosis going in the favor of glomus tumor. On audiological investigation, she was having mild to moderate mixed hearing loss. In the left ear, type A tympanometry was normal. Which of the following sign is not related with the patient? Nicely formatted question. That is, the patient is having a typical history of red mass with pulsatile tinnitus. Referred autalgia is there. Means glomus tumor. If glomus tumor, which are the following sign not related with the patient? What is flap sign? Flap sign is a clinical finding, not at all. It is your radiology finding. What is flap sign? Flap sign is this is carotid artery, this is jugular vein, there is some bony partition, and if there is a glomus tumor, this glomus tumor damages the bony partition. There is a loss of bony partition between carotid and jugular. Flap sign is present. Brown sign. What is brown sign? Anyone who can write in the chat box. What is brown sign? Brown sign is your blanching of the tumor on exerting the pressure. Blanching of the tumor on exerting the pressure is your brown sign. Again, a feature of glomus tumor. Aquino sign. Blanching of the tumor by pressing neck vessel. Aquino sign. Battle sign. Battle sign. Anyone who can write in the chat box. What is battle sign? Is in the skull fracture. Battle sign, ecchymosis below pinna. This is a fracture part, nothing to do with the glomus tumor. One more sign, which is a fourth sign. Let's see who will reply. Which is the fourth sign in the patient of glomus tumor? The fourth sign is here, a rising sun sign. When the tumor increases in size from the floor, it is here rising sun sign. Clear? Which artery we embolize? I can ask you. I can give you this clinical MCQ. I can ask you, patient, which artery we embolize to reduce the size of the tumor? That is ascending pharyngeal artery. Beta. In this patient, ascending pharyngeal artery we ligate to reduce the size of the tumor. Dr. Share, beta, why you writing Meniere's disease in MCQ? Okay. Brown sign is pressure on tympanic membrane. If you pressurize the tympanic membrane, blanching is there. That is your brown sign. That is brown sign. Clear? Ascending pharyngeal. What is the treatment of glomus tumor? Is surgical excision. We use CO2 laser in the patient of glomus tumor. We are using CO2 laser. Clear? Coming to the question number 19. Tullio's phenomenon. This is already we have discussed in nice way. Tullio's phenomenon is recruitment. Patient is feeling very uncomfortable in the noisy surrounding. It consists of the dizziness induced by sound in all of the following except perilymphatic fistula. Yes, any fistula. It can be because of infection. It can be because of trauma. Post fenestration surgery, when we do type 5 tympanoplasties, fenestration surgery, there is a high risk of fistula formation. You can appreciate Tullio's phenomena. Meniere's disease, sensory deafness. So Tullio's phenomena already we have discussed. It will be either seen in the sensory deafness or it will be seen in any fistula formation. So A, B, C, they are the differential diagnosis of Tullio's phenomena. Acoustic neuroma, nothing to do with your Tullio's phenomena. Golden rule. This is my what we have to, which level we have to reach? Sensory deafness or neural deafness. both compete with each other. Let us have a competition between sensory deafness, neural deafness. Sensory deafness give the first hit. Why? Oversensitivity. Sensory deafness, people say I am oversensitive people. Neural deafness, they say we show phenomena of fatigability. We show. Sensory deafness, I have recruitment phenomena with me. Sensory deafness say I have rollover phenomena with me. Sensory deafness, I use SISIABLB for my diagnosis. Neural deafness say I use decay test for my diagnosis. Can you appreciate it? One day before NEET examination, sensory deafness is equal to oversensitivity is equal to recruitment phenomena is equal to short increment sensitivity index or ABLB, alternate binaural loudness balance test. This is feature of sensory deafness. Neural deafness, fatigability, rollover phenomena, decay test. That is your neural deafness. One day before the examination, conductive deafness, they say we are comfortable in noisy surrounding. Paracusis will say. Sensory deafness say we feel very discomfort in noisy surrounding. Tullio's phenomena. Paracusis will say inversely proportional to Tullio's phenomena. Tullio's phenomena, discomfort. Conductive is comfort. Can you appreciate what on this platform, what message I am giving you? Work hard on the keyword, work hard on the concepts, because it is a qualitative learning. This is a game of qualitative learning. बेटा मिनिमम पढ़ना है, बार बार रिवाइज करना है. ईच एंड एवरीथिंग शुड बी ऑन योर टिप्स. अभी आपको मेरे सारे फंडे बहुत अच्छे लग रहे हैं. जब मैं आपसे टूडियोस पूछूंगा ना, एमसीक्यूज एग्जाम इन द एग्जामिनेशन में, बेटा कुछ क्लिक नहीं करता. हमने कहाँ पढ़ा था, यहाँ तक क्लिक नहीं करता. टूडियोस ईएनटी में पढ़ा था, इतना भी क्लिक नहीं करता. Until unless we revise it 4 times. So minimum 4 revision is required. Coming to the last MCQ, 50-year-old female, ENT, OPD, vertigo for few seconds. The first keyword, the keyword of the MCQ, it is for few seconds without hearing loss. Favorite MCQ, favorite choice of All India Examiner. Beta, whenever they ask you this question on BPV, benign paroxysmal position vertigo, they always say which of the following is a false statement, and they give an option: mild to moderate sensorineural, moderate to severe sensorineural deafness. Always remember, in BPV, benign paroxysmal positional vertigo, golden rule: no CNS symptoms, no hearing loss. This is the golden rule of BPV. Just remember, there is no CNS symptom, there is no hearing loss. No CNS symptom, no hearing loss. Vertigo for few seconds. What is the pathophysiology of the topic? क्या concept है? एक बच्चा अपने घर से निकल के किसी और के घर में चला गया. One child get displaced from his house to somebody else's house. कौन सा बच्चा? Calcium carbonate body. उसका घर कौन सा है? मैक्यूला. वो कहाँ चला गया? सेमी सर्कुलर कैनाल. कौन सी कैनाल के अंदर? पोस्टीरियर सेमी सर्कुलर कैनाल. इट एंटर इनटू पोस्टीरियर सेमी सर्कुलर कैनाल. व्हाट इज द इन्वेस्टिगेशन ऑफ चॉइस? इन्वेस्टिगेशन ऑफ चॉइस इज हॉल पिक मैन्यूवर, व्हिच precipitate the symptom. We take the patient to a position where he or she get the symptom. That is Hall Pick maneuver. What is the treatment? Treatment is reposition exercise. And what I am asking you, identify the diagnostic maneuver. What I am showing you, what's like, this is some printing error. It is not diagnostic. In maneuver, you find the therapeutic maneuver. You have to find the position. Please, we will rectify this question. So it is therapeutic. What I am showing you, this was your INICT MCQ. 2020 or 2021, they have shown the same slide, and this is your Foster's exercise. This is your Foster's exercise, beta. Clear? So among the 4 options, this is Foster's maneuver. If examiners show you something like this is Appley's maneuver. अगर बेटा एग्जामिनर अगर आपको ये कुछ दिखाएगा तो it is Appley's maneuver. The first 3 steps of Appley's is Hall Pick. First 3 steps of Appley is Hall Pick maneuver. If examiners show you this slide, this is your DARF. In the last grand test I have given you this question. This is your, all steps are Appley's. Absolutely yes. This is DARF, DAROFF, DARF exercise. This slide I have shown you is your Foster's. And if examiners show you something like this, it is Semont's maneuver, S-E-M-O-N-T, Semont's maneuver. Done. So beta, these were the 20 MCQs. Take my word, beta, you have to make your own history. वो दिन याद है ना बेटा, when you cracked your UG examination in 12th standard, you changed the whole history of your family. So don't belong to an era. You start making your own, and you people have the potential. Every student listening to me, you have the same IQs, you have same potential. The only point is those students who come out of their comfort, they create history. Clear? So just try your best to work on qualitative learning. Minimum comfort level should be there. Try your best to revise more. If you ask me, I will repeat this thing 100 times. Give it up, please revise. If you're studying for 3 hours, 1 hour should be focus on revision. 3 hours, new topic, then 1 hour. Out of 4 hours, 1/4 time, 25% of the time should be given on revision part. Cirrus Oridis Media, can you ask me the query, beta? Can you write the query in the chat box? Which point you want me to ask? Can you tell me the question number? Okay, so better focus more on the revision part. You can ask me all the queries, all the points. For all the updates, you can follow on the Insta. You can inbox me on the Insta. Okay, so I will try my best to reply as soon as possible.